Hey, OncoPT, and welcome to this episode of the OncoPT podcast. Today's guest is someone that I have wanted to have on the podcast for actually probably several months at this point. And the universe has finally aligned. I've got him on the podcast, y'all. I'm so excited to welcome Dr. Matthew Johnston to the OncoPT podcast. And we are going to talk about something that we haven't really talked about on the podcast. So, Matt, welcome to the podcast.
Thanks for having me. I'm super excited to be here. Like you said, this has been several months in the making, and happy we finally connected and able to, talk about prostate cancer.
Oh my God. This is so exciting. So, can you tell us a little bit about how you got into PT and specifically how you got into cancer rehab?
Hmm. So I was in high school, and my mom had suggested to become a PT, and that's as simple as it is. And I went to school, and I was in a program where like your undergrad flowed into PT school, and then you kind of
Nice.
blinked and it was all over. And so I started working in orthopedics and had some pelvic health issues of my own. My wife is actually also a PT, and she went to a program where they talked a lot about pelvic health. They had a professor who was a male therapist treating men in, pelvic health. And she just said, "Oh,
Mm-hmm.
you should talk to him." Like she kind of kept like encouraging the conversation. Because I was thinking, oh, maybe I'll get into this, maybe I won't. Like I never thought I'd
Mm-hmm.
be the pelvic therapist in PT school. And I connected with him and took a course, and the rest was kind of history. And that was a couple of years ago at this point. So it's been a very interesting ride. I did not think I was going to be working with patients with cancer when I was, going into pelvic health. I thought it was a lot more like pain and urinary issues and that kind of stuff. And
Mm-hmm.
then, oh, by the way, like we do talk a lot about prostate cancer in a lot of the courses, and I just kind of like fell into this world, and here we are.
Oh
So,
my God. What a turn. And looking back on PT school, and I don't know about you, but just thinking about how wide-eyed and completely unaware and just so innocent and optimistic and being like, wow, that feels like a lifetime ago. Look at all the things that we've done since then. So,
mhm.
quite the ride. At what point, once you started your pelvic floor education, did you realize, oh, prostate cancer? This is a really big deal. A lot of patients are experiencing this. I want to help with this.
That's a really good question. So I had first started seeing patients. I was a clinic director. Pelvic health was just kind of something I was like getting into, and it wasn't like my main 100% focus, just because I had so many other things going on.
Mm-hmm.
So then my wife's job took us to Maine. So we lived in Maine for like 7 months. She was there for work. She's also a PT, and I had no idea what I was going to do. I thought I was going to do travel PT, and that like wasn't clicking. And so then I like started sending my resume out to like just regular old you know orthopedic practices. Who wants to hire
Yeah.
me for 7 months? Here's my situation. It was also at the time where people were really needing therapists. It was a very good job market for like come
Nice.
work for us kind of thing. So I like put my name out there and heard back from this practice. Um, and they just so happened to have a pelvic program for men who a male therapist just like ended up moving to Nebraska or something, and he just had left. They had this like huge practice full of patients, and I was gonna do it like 1 day a week and do like home care for like 4 days a week. And I said, okay, let me just think about this. And then I talked to the program director for the pelvic health program, and she really sold me. Her name is Jill Cramp, and I have to give her a shout out because she just like changed the game.
Oh,
I
I love that.
did not think pelvic health could be like something I could do full time, or something that you could have such a big impact on people's lives, especially prostate cancer. So she is A plus. She does a lot of great work in the state of Maine. Very happy to have connected with her. And she has really like guided me down this pathway of prostate cancer. So I've learned a ton from her, and just kind of it's set up everything that has come on since that. So
Oh my
yeah,
God.
huge shout out to her.
That is so wonderful. Was there anything in particular that she communicated to you that was the selling point of,
Mm.
I got to do this?
I think it was just like her passion. She has just this intensity of her that is just I know my core values, and I just like, that's how I make all my decisions. And I was just like, I want that. I want whatever she
That is
has.
amazing.
And it just ended up clicking. And, you know, when you're in this like small niche practices and you don't see someone doing what you want to be doing, you don't think it could be done, you know, and you go, you know,
No.
you coming from the orthopedic world, like pelvic health was something that people do 50-50 in, like 50 orthopedic, 50% pelvic, or you're in these like very small, you know, cash pay clinics that are all female oriented or pregnancy
Yep.
postpartum. They see men sometimes. Like no one was doing what I wanted to be doing until I've kind of like connected a little bit more into the world. And there's definitely a lot of other therapists treating full caseloads of male population. But that was really the first time I saw
Mm-hmm.
like, oh, this could be done, and you know, it can be done in a way that is just like connected to that population. So.
Mm-hmm. I know I'm asking you to, answer this humongous question that's probably plagued our industry for many years. But so in my area here in Texas, there's a couple kind of what you described, like very niche, almost boutique pelvic floor clinics that personally, like I've been a patient at and I really enjoyed. But they are, historically, or at least the ones that I've encountered, tend to be focused more towards, women who
Mm-hmm.
are mothers and whatever. And as a non-pelvic floor therapist, that's who I refer to because I know like I got really good care there. I know they're going to take care of you. But I imagine that experience of walking into this very like beautiful, feminine, clinic or, space might be a little off-putting, or maybe, am I in the right place
Mm-hmm.
as, a man who has experienced prostate cancer? So why I have lots of questions. I'm trying to like zoom it in here. Was that something that you saw in your own early practice
Mm-hmm.
within pelvic floor specifically for prostate cancers and other men?
Yes and no. Like I've definitely had patients make comments related to that. Like the only person I could find was, you know, X, Y, and Z person. Or I went to this clinic and I felt a certain way. And I think, you know, there's a time and place for every clinic. You know, our profession is so broad and so deep. You know, we like do everything and do it to an intensity that I think no other profession really does. You know, compared to like other, unless I guess occupational therapy, speech language pathology, like you know, more allied health. You know, we just have like we have a way about doing things. I think that is
Yeah,
special. But yeah, I think that there's patients that do echo that. But I
mm-hmm.
think sometimes like sometimes that's the only option, you know, and we need those therapists. Like we need those
Totally.
clinics because they serve patients that there's not enough people, and like there's not enough people who want to do just men's health or just prostate cancer health care. You know, like there's just not enough of those available. So we need those therapists,
Totally.
and um,
Totally.
you know, I'm grateful that they're there because sometimes if you're in a location that doesn't have anyone else as an option, like they're willing and able and ready to take care of someone, and that's amazing.
I do agree with the passion. I think there's such a fervor that PT has about PT in a really cool way. I do love that about us.
Yeah.
So once you started practicing within, pelvic floor, was it immediately of like, we are looking to build a men's, like a program for men experiencing, the impairments after prostate cancer? Like, how did that kind of
Mm.
come together for you?
When I was in Maine, it was like already there. I was kind of served it on a
Mm-hmm.
silver platter. I didn't really have to do anything other than treat patients, and it was very, very nice. And then we have since moved back to Philadelphia, where I'm originally
Mm-hmm.
from, and that was a different conversation. More of that was me starting something, saying, "Well, I want to do this. I'm going to continue doing what I really want to am passionate about.
Very cool.
Is
Yeah.
that possible?" And thankfully, my boss has been nothing but amazing and says, "Sure, you know, like you are like it's on you. Go make connections, do what you need to do, and like we'll support you." And that's been amazing. So
Mm-hmm.
it really was just me taking that passion and just continuing it in a new geographic location,
Yeah.
and just finding like relationships in the community, you know, physician relationships, but also like you know sex therapists, other
Yeah.
like oncology. Like the place I work for has like an oncology wing to it, not geographically, but like there's no physical wing, but there's a branch of our service line that has oncology. So I connect a lot with them, and like we
Yeah.
cross refer, and like so there's just a lot of like network capacity, which is nice. And then
Mm-hmm.
like educating other therapists, but also like the physician relationships also too.
Mm-hmm. Very cool. Okay, so we've been talking around it. Let's kind of get down to the meat and potatoes. So we know here on the OncoPT podcast that it's not a matter of if you experience side effects after cancer treatment and during cancer treatment, it's kind of when. And I imagine that the same goes for our prostate cancer survivors. Can we talk a bit about what kind of side effects these patients are experiencing, and then some of the why? What are
Sure.
those contributors to those side effects that you see commonly in your practice?
Sure. Most of my practice is post-surgical prostatectomies. Um,
Mm-hmm.
I guess we'll talk a little bit more about like other treatment options, radiation, hormone replacement, and how that affects patients that I see.
Yeah.
Um,
Yeah.
so in the prostatectomy world, most of these patients, have surgery. I will see them either before or after surgery. And then the biggest complaint I think, is urinary leakage, urinary
Mm-hmm.
incontinence. That's typically like the number one problem that people experience and they're most concerned about. But then related to that surgery, there's also sexual side effects. Um, Sometimes on rare occasions, pain, hernia issues. Sometimes there's underlying bowel issues that we just kind of clean up because, oh, we're here, we might as well kind of take care of this like full,
Yeah.
well-rounded piece of the puzzle. And then sometimes like abdominal issues. This is an abdominal surgery, so they're cutting into abdominal musculature. So we're depending on the patient, but most of them we're doing some sort of like general strengthening program, aerobic conditioning, like long-term cancer kind of survivorship piece. So we'll do some of that too.
Very cool. So that was kind of the surgery side of things, which is interesting now that I'm thinking about it. And I think it's just because of who I tend to see in my practice.
Mm-hmm.
I usually don't see a lot of patients after prostatectomy. I tend to see, here's where I tend to see patients more after maybe radiation therapy, but I almost see more patients who have advanced prostate cancer and are
Mm-hmm.
doing more of the chemo or maybe other kind of medications. It's more of like a, I don't know, like the goal is not curative in that
Correct.
nature, but it's like how can we get
Like
on top
quality
of
of
the
life.
disease as much as
Yes.
possible? Yeah,
Yes.
yeah. And so it's really interesting that that's just something I haven't seen a
Mm-hmm.
whole lot in my practice. So getting into like the radiation and the other cancer treatments, what do you see there, Matt?
Sure. So every obviously patient is different, but most of the time patients will come in, they'll have prostatectomy, and then like a month, 2, 3 months later, they'll get like follow up PSA testing, and then they'll say, oh well,
Mm-hmm.
I have some sort of continued disease process, whether that my PSA goes up or I see something on a PET scan or some sort of other testing, where
Totally.
then they get some sort of secondary treatment, and that typically is radiation or hormone replacement therapy. Um,
Mm-hmm.
that's my typical patient population. I have seen
Mm-hmm.
some of the folks that you're talking about. Well, they have more advanced, disease, and they're getting chemotherapy, or other treatment like that, kind of more intense,
Mm-hmm.
acute symptomology. I would say, like versus
Yeah.
like the radiation and the hormone replacement is kind of like low but long. That's kind of how I kind of group
Yeah.
people, I guess. Radiation, we typically will see something like stiffness in pelvic floor muscles,
Mm-hmm.
constipation, fecal incontinence, those types of more bowel oriented symptoms.
Yeah.
And then the hormone replacement symptoms, we kind of see a little bit of everything, like the typical fatigue, nausea, weakness, change in like adipose, like change in like water distribution, hot flashes. We'll typically see
Yeah.
changes in sexual functioning and side effects there. So we kind of see this like kind of a widespread um, symptom presentation in the hormone replacement group. And I think that's like
Mm-hmm.
the bread and butter for the typical oncologic PT, because you guys are great at treating the like fatigue part of it. And I've learned so much from your podcast, so thank you.
Thanks.
Because, and that's sometimes where I'll make the decision depending on patient's geography is say, all right, we've cleaned up the pelvic stuff. Obviously, if someone lives in the neighborhood, I'll kind of continue on with the like
Totally.
strengthening part and like that kind of thing. Especially if they don't have like secondary treatment going on. Like if they just had a prostatectomy and they're done, like we're strengthening that person. We're picking up the weights. We're doing like intense stuff. But if there's someone who's like, especially the hormone replacement people, like I'll typically like, well, you live 45 minutes away from me. Like you should probably go see someone in your neighborhood and get that taken care of and start the journey now while it's new and the symptoms are not kind of like weighing down on you and it's not months and months and months and months in the making. Do it now. And we just started like and that's a big kind of push that I try to make for a lot of patients. I'm getting better at this. When they come in on day one, say like, well, I want to get you to this point. And that's usually incontinence free and mostly pad free. Like I usually say like 90% pad free, just because 10% is like for weddings and special occasions and things that they just want just in case.
Totally.
But I want this because if any other treatment needs to happen on top of this, I want you on a clean slate. I don't want you to have pelvic problems plus hormone replacement therapy or plus radiation. Like I want the waters to be as clear as possible. I don't want that muddy, murky middle to get you in trouble because then we're dealing with a lot of other symptoms. And those treatments can affect urinary incontinence too. So it just makes things a lot harder. So I really try to push for that in terms of like time frame.
You talked a little bit about it, but I want to push more and get some more information. When you're making a decision, so we know that patients who have cancer and have gone through cancer treatment don't experience just one side effect or one impairment. It's often multiple. And that adds to the fact that they're human and that they have other issues potentially going on. So I think a lot of times people are very aware of, you've got a young mom who's diagnosed with breast cancer. Well, we've got the breast cancer, but then we've already got that pre-existing pelvic floor potential issue of, they were pregnant and they gave birth and all these other things.
Yeah.
And so we cannot truly just say, well, you've only got oncology concerns that I need to be aware of. You also have pelvic floor. So, when it comes to a patient who's been diagnosed with prostate cancer, how do you kind of maybe prioritize or decide, should they do pelvic floor PT first, or would they benefit from, maybe like a straight oncology PT, for example?
I think it depends on what their goal is. I mean, to me, this is my slant, but if someone's leaking urine, they don't typically want to exercise because that typically makes it worse.
Absolutely.
And sometimes we treat them like co-treating, so they'll do both at the same time. I typically only see patients once a week for the most part, So hypothetically, they could do 1 and 1 or 1 and 2. It depends on the frequency, but sometimes we'll co-treat patients. I think it depends on what their goals are. If they're like, I want this leakage to be gone, and then I will exercise, that is a perfect kind of segue. And that referral process can happen. And I think you talk a lot about this on here is like knowing who's in your neighborhood, know who your therapists are in the neighborhood, who does what, and make those connections because that patients love that. And they're more likely to go to, if I say, oh, go see Elise, she's amazing, she'll take care of your, fatigue issues, versus you should probably get therapy from an oncology therapist. Like that is so vague and no one's going to do that typically. So, if you can make that like a very easy handoff, I think that goes a long way. But I think coming back to it is trying to really get a sense of what the person's goal is, what's most meaningful to them. Because you're right, like there is a fine balance between treating kind of like pre-existing pelvic issues like incontinence from surgery, but also treating the hormone replacement side effects or other side effects that they're experiencing like right now. Sometimes I think that depends on the time frame. Like if someone's years in the making and they've had hormone replacement for a long time, like maybe those symptoms are a little bit more weighing down on them, and that might be something that they're not going to mind waiting a little bit longer for, and they really want to get that incontinence piece. So again, I think it's like good questioning to patients and good subjective interrogations on like really trying to get to the source of like what is the most important to you.
I really like it. I really like your approach of, well, what does the patient want?
I know.
That was one thing. Yeah, go ahead, Matt.
No, I was just gonna say, like, sometimes I think we have this like pre-formulated plan, like thought, like I have the perfect plan for my
Yeah.
prostatectomy people, and sometimes they come in
Yeah.
with other things, and they're really worried about the scars on their stomach, or their sexual function, or and my brain likes processes and like order, and it's like, well, we got to work on the incontinence before we do anything else, and like they might not care, right? And if you try to push your agenda on someone, you just like lost them forever. So
Totally.
I think that that therapeutic alliance piece, when they talk about it in schools, like it's no joke, and it can make or break you. And it makes, at the end of the day, that's the patient's outcome. Like they can't do it without us, but we can't do it for them either. So when we're talking about this
Yeah.
like building relationship, that like like those are like the skills that are like just paramount to good relationships, and especially when we're talking about something like cancer, right? You know, I work with an older population of men between the ages of 50 and 90, who don't want to tell people that they're afraid and scared and emotional, or this medication is making me feel a certain way. Like you gotta have like space for that and questions, and it's still like a skill set I'm learning, because in the orthopedic world, you ask these questions and patients get emotional, and there's stress involved with an injury and all that stuff. But the game has changed when we're talking about someone's like being diagnosed with cancer, right? So I think that is just a powerful um, thought process, and something that maybe we should all like reflect on, because it's hard. It is really hard. It's a hard skill, and we all could like, I think, just try to approach that a little bit more gently to patients sometimes.
Matt, I really appreciate you being very upfront and honest about how this is a skill that like we're still working on. So I have a
Yeah.
patient that I'm working with right now, um, not prostate cancer, but is having this issue that she actually told me about a year ago. And we kind of, did some problem solving. I'm like, what is
Hmm.
this? What's going on here? And for what I understood, for what I thought about it, I was like,
Mm.
okay, we've taken care of that. And then last week,
I
this
have been
patient
here
calls
so
me and
many
she's like,
times.
hey, you know that issue I told you about last year? Like, let me look back through my notes because I don't. And sure enough, it was almost to the day. She's like, okay, so it's still going on, and it was so funny because like we chat all the time. I've seen her for quite a bit. We have a good relationship, and she kind of got like quiet for a bit. She was like, so it only happens after sex. And I was like, you could have told me that a
Mm.
year ago, but at the
Yeah.
same time, that therapeutic alliance is so, so critical. And I had not established an environment in which she felt comfortable
Yeah.
saying that, oh, yeah, by the way, this thing that I've told you about that's weird, it only happens after I've been intimate with my husband.
And that's like
And so I
such a
think this,
valuable piece of information. Like that has
oh my
probably
God,
changed your whole thought process.
it certainly adds more layers to the picture, right? It's like,
Yeah.
oh, this is okay, like, let's get to work and whatever. And
Yeah.
so
Yeah.
we've been
Yeah.
working together on that. But, and that's someone who is the same sex as me. And, I think culturally, we have to be appreciative of, there's going to be people who are comfortable talking about this. There's going to be people
Hmm.
who are not comfortable talking about this. But I don't know that environmentally, socially, we've really curated an environment for, especially our older men diagnosed with prostate cancer to really be comfortable and curate that safe space to have those conversations
Hmm.
about this is a problem. And, then I appreciate what you brought up earlier. We're layering in mortality on top of all of this with the cancer diagnosis, right? This isn't just, oh, I hurt my shoulder, which, like, I'm
Right.
sorry you hurt your shoulder. But now we are talking about, there's death that we have to think about too, on top of I'm leaking, I am having difficulty, being intimate with my partner.
Sure.
Like, oh my God, there's so many more layers to all of this.
And how do you open the door for patients to tell you what's important to them, but also still
Yeah.
get stuff done? you know, like there's been definitely times where I've like spent a lot of time just like listening and talking, and creating space for people to tell me more about why that's important to you, or like just kind of these like very curious, open-ended, vague questions. And sometimes they don't like that, but sometimes that's just like, well, why? Like I'll pester them a little bit more, I think. But, and then they'll say, well, I don't think this is like relevant, but, I broke my tailbone 2 times, they say like these crazy things. It's like, well, that would be important to know about. Or sometimes, and this was a like a naive point in my mind. It's like, getting these patients coming in for prostate cancer and prostatectomies primarily. And then, I've gotten in the habit of saying, well, have you had other cancers before? And have you had any treatment for this prostate cancer other than a prostatectomy? Because sometimes they'll say, well, yeah, I'm getting like hormone, like they'll be doing stuff and they don't think that's important to tell me. And I'm not asking the question either. And I'm just assuming that like that cancer checkbox just means prostate cancer and not whatever else. And sometimes like that makes a big difference in like how they're, what our goal setting, process is, or our prognosis process, or, a variety of other things. But it's just, it's easy to skip over when they're like just in there for a certain thing. Again, you have that like pre-programmed thought process. Yeah. Tunnel vision, like literally. Yeah, and
totally.
It's like, I've been really trying to get in the habit of like, well, what's bringing you in here? Sometimes they'll say, well, the doctor told me to come. Like, that's one thing. Okay, well, what's important for you to work on while you're here, and start that way versus like, all right, when surgery, are you leaking now? Like, blah, blah, blah. Like, that like script that you kind of get into. And there's certain questions you need to get done. But sometimes like if you open the door to saying, what's bringing you in, they might say, I'm really nervous. Like, I'm really afraid of being here. Like, and I don't know why. Like, I don't know why I'm here. Like, so I think, and that can be something where you address that first. And then they're going to be more apt to tell you other things later on. So.
I just did an interview with Dr. Adam Matichek, and it was more about trauma, oh my gosh, trauma-informed care. Holy cow. That went out the window there. And honestly, Matt, the amount of things that I remember Adam saying, and then I hear you saying, they're married so well here, and really about, really establishing that therapeutic alliance beyond the checklist or the script that we learned how to start in PT school. And really kind of, and man, this is so hard. But kind of letting things flow a little more so that you can pick out those tidbits as they come to you. Because a lot of times, if I stop talking long enough and just listen, which y'all know I love to talk because I have a podcast. If I stop talking long enough, my patient will usually tell me the answer to the question that I want to ask, or I'm going to ask later on down the road. And this is such a good example of that.
I always thought that was a cliche, like, physical therapy professor thing. If you just listen, they'll like tell you, and like, the Maitland philosophy uses that a lot, that like phrase. And I'm like, this is not real. And the more you really kind of like hone in on that skill set and really like practice it, like as a skill, the better it gets. Like the more accurate you are, and like the more direct patients, you're being to patient care, and they're happier and you're getting better result. Like there's just like so many things that go down that path. And I think we get so transactional in our care sometimes, and it's just the next person's coming on the next hour, and it's hard to kind of like reset your brain and mindset to say, okay, well, this is a whole new person with a whole new agenda. And what the agenda was for patient number 1 is not the same agenda for patient number 2. And that's a lot of extra work sometimes just to like get in that reset.
I have so many kind of wheels that are turning right now, Matt, on like, this is such an important topic. Honestly, like we could probably have a whole other interview on this. So I might have to have you back to chat more about that. It's interesting that, which like there's a very specific reason why we want clinical practice guidelines and we want evidence informed. I'm thinking back to, ortho and PT school, we learned about these, I'm totally going to forget the name. I'm so sorry, PT school professors, but like we had these boxes of, like back pain.
Yes.
Low back pain was, it usually fell into one of these boxes. And as a PT school student, I liked that because there was structure behind it. There was a map to follow. And when I started practicing in oncology, I was like, there's no map, there's no box. And it's so interesting now because I craved that so much, but now, like, not the case. It's very much like, let's kind of see what happens, because sometimes I will be surprised. And, of course, there's the physical impairments that we deal with as physical therapists, but, I have another patient right now who is dealing with pretty significant diagnosis, but for her, like, physically there are impairments, but the cognitive, emotional, psychological aspect is so much more weighing more heavily on this patient's minds. And so that's, the other day when I saw this patient, we probably sat and talked through things and, did a lot of education, way more in that session, like 40 minutes or so, more than what, like usually I'd like to be doing therapeutic exercise, but it was like,
well, I think that's
that was
the
what
mindset
was needed.
Yes.
Yeah.
And that's the, like, I think sometimes we get this, and I don't know, imposter syndrome or whatever, but, as physical therapists, we want to do exercise. We want our hands on the patient. We want to, get on the bike, man. And sometimes patients don't need that. They need what you just said. It's like they need 40 minutes of education and reassurance and a plan, and someone to brainstorm the plan with them and tell them, here's how we, like, sometimes we do that. We, like, troubleshoot scenarios for a whole hour and talk about how, you're going to deal with urgency and, deal with sleeping at night and pad changes and, like, all these things. Like, that's way more valuable. Sometimes, yes, like, they need to know how to do a pelvic floor contraction and, like,
totally
strengthening. Totally. Like, there are some non-negotiables. But once that process is done, well, sometimes you got to take a detour, and that might be the thing that, like, stops the progress. And if you just blow past it, well, you're missing the boat on that patient. And, then they start losing steam and you're like, why is this person not getting better? Well, you're not addressing what they actually want to address. And, there's a time and place for the exercise part. And I think that is what makes us physical therapists. But I think sometimes we need to flex those muscles that are motivational interviewing, behavioral change. Like, behavioral change is such a big piece. Like, how do you get someone to exercise who feels like crap because they're on chemotherapy? Like, that is behavior change. And sometimes you need to dive into that. They know what to do. They just don't feel like doing it. Or their body, like, cognitively, or fatigue state, or, like, some of those other variables related to, like, side effects. Those are the barriers. Like, we need to go through those. Not get on the bike and know how to pedal. Like, they don't do that. And that's, like, when we're talking about skilled therapy, like, that is skilled. Like, training someone how to, like, navigate those obstacles, certainly.
Okay, Matt. So I needed this interview to happen about 4 years ago when I was working with a patient. So I'll never forget him. He was a really special patient to me. So he had metastatic prostate cancer. And at the time I was seeing him, I think he was being treated. This was like multiple lines of therapy that we were on at this point. So I think he was undergoing treatment with cisplatin and maybe Lupron. Those are the ones I remember, at least. And so for him, first of all, he had bony metastases that we were working around. And so, I was trying to do a lot of exercise because I knew he needed exercise because we were working on different things. But I remember my sessions, and I remember doing exactly what you're talking about here, which is, I got to do the exercises. I got to get through these exercises. When in fact, the reason we weren't making progress is because of all the other things that were going on and the barriers, like you literally just spelled out here, Matt, of he was fatigued. And not only was he experiencing cancer-related fatigue, but unfortunately, he was also dealing with, he was unable to live on his own. And so he was bouncing between his adult children's homes and was sometimes sleeping on the floor or on a blow-up mattress. Of course, you're not going to get good sleep when you're on the floor or on a blow-up mattress. And then he was dealing with all of the side effects of his hormone therapy of, this is not a great descriptor, but sometimes I think it drives the point home of this menopause almost, where
Yeah,
it's
yeah.
the hot flashes, and he was experiencing some really problematic mood changes and different things like that that were absolutely barriers to him participating in
Hmm.
his home program. And I just blasted through all of those for so long, and then I was like, this patient isn't making much progress. Well, I wonder why. Like,
Yeah. It's
oh my
funny. I had
god.
a very similar story literally today. This patient had a prostatectomy, and he's stress incontinence is kind of resolved, and now it's just like this like underlying urge issue. And he's telling me about how he pulls into the driveway, into the garage, has to undo the code, key in the door, and like all these things. And I was like, oh, I was like, the bathroom's literally right next to the garage door. I'm like, all right, here's what you do, like blah 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 blah, like go down my like spiel. You're gonna be perfect. And he keeps coming back, and it's like the garage, the garage. Like I'm like, all right, well, there's something about this garage that I am missing the boat
Yeah.
on. And
Yeah.
today we literally talked for like a half an hour to, well, I keep my bag in the trunk, and I have to pop the trunk, and then I have to get the bag out of the trunk, but then I don't wear the shoes in the house, so I have to take off the shoes and put my slippers on. But then
Yeah.
I like to orient my shoes a certain way, and like hang up my bag, and the car needs to be kind of pivoted in the right spot, and like all these. I'm like, that's like 20 minutes of extra time that I was just not accounting for, and
Totally.
it
Totally.
it completely changed the course of like the intervention strategy. And and he was like, I don't want to bore you with these like things. And I was like, this is like the meat and
This
potatoes
is
of what the
important.
problem is.
Yes.
And
Yes.
I just, and I think sometimes like he's kind of curious about why he is not exercising sometimes. And then he kind of gets it, and he was like, wow, you're like, you know, he'll make comments about like psychology. And I'm like, kinda, but it's like, this is like behavior, this is a behavioral problem. This is not, can you hold a
Yeah.
pelvic floor contraction long enough to get there? This is
Absolutely.
you got a lot of things going on before you get to that bathroom door. And if we cut out half of them, like you're probably gonna be okay. So
Yeah.
I think for him and for me, it was like a huge learning experience about, well, is there anything else about this garage I don't know about? Can you walk me through, like, from get out of the car and like, what do you do? Like, tell me more, and like let the patient like elaborate without interrupting. Because we all like to interrupt. We all have agendas. But it changed, and I'm really interested to see when he comes back if it make a difference. But he really seemed excited about like, wow, we actually seem to get to the source of this problem. And I was like,
Oh man.
it kind of sounds like we did, for the first time. But that happens all the time.
And how cool is that? I mean, how validating is it to, when you're trying to explain something to somebody and they're like, "Oh, I get it now." It's like, "Oh
Yes.
man, I feel so seen." Like,
Yeah.
man. And oh, I get so excited. I feel like lately so many of the interviews that I've done have just connect on such a deep level. So I recently interviewed Dr. Katie O'Bright, who's really big into primary care. And we
Mm-hmm.
talked a lot about, really understanding from this primary care lens of what is the environment in which that patient exists, right? And, I think I did, and, now talk like you talking through that garage example. It opened, like, it's like a film was lifted off my eyes, because I have a patient right now who lives in an apartment.
Mm.
And so I have an idea of what an apartment complex looks like, because I've lived in a couple apartment complexes. I have no idea what this patient's apartment complex looks like,
Yes.
other
Yes.
than the fact that she has 3 steps from her parking spot to her, front door, whatever that is. What about inside the unit? What does she have to walk through or around to get to her unit? What else am I missing? Because I
Yeah.
know I'm not asking these questions. And this is so eye-opening, Matt, of, again, you and we probably pull into our garage door
The same way every time. Don't think about it.
same way every time, and it's not even a thing to think about.
Yeah.
Like, oh my God.
It's funny. I find myself saying, walk me through how you do this a lot. And especially in
Mm-hmm.
public health, well, we don't watch people do some of the things that we need to know about, right? Like
Oh,
if someone comes in with shoulder pain, show me how you reach above. Show me how you reach behind your back. You can see all of, take your shirt off. Let me see everything about how that scapula moves,
Mm-hmm.
like your thoracic spine, like everything. In the pelvic health world, sometimes we don't have that luxury. So the way I get around this, like, well, walk me through like how you urinate, like as dumb as that sounds, but like there's more than one way to do it sometimes. And like
Absolutely.
you kind of
Absolutely.
take that for granted when you grew up and you do it, like it's the same way it's always been, like, so I think
No.
that is just like a powerful way to learn about patients and how they were taught to do things in life.
Oh man. I know I invited you on to talk about prostate cancer specifically, but I feel like we have
taken a detour.
We have taken such a deep dive into so many things that extend beyond prostate cancer that I'm really excited about. And so, anyways,
I have a tendency to do this.
I love that. I'm really kicking myself. I know, like, I wish I had you on the podcast sooner, but also I don't think I would have been in tune with so many of these just nuggets that you are dropping, Matt, throughout this podcast. Because, like I said, I literally just within the past couple weeks have interviewed these people and then have these patient interactions. I'm like, oh, I think I understand that now. That's
See,
so
if we did this
exciting.
6 months ago, we would not have connected this way. So,
Absolutely not. Oh my God.
and it's interesting. Like, again, these are skills, and sometimes you just don't have the mental capacity to do it that day, or like you're rushed or they're late. Patient's 20 minutes late, and you just like need to get the basics done. Or they're not in the mood to like take this journey. Like something happened at home or work and school, and they're just not. I have this patient who like totally hates when I ask these like open-ended questions, and I like as soon as I say it, he like makes this face, and I'm like, all right, maybe give him some options back. So, sometimes like patients don't want this, like that.
Yeah.
Let's be clear about that too, and sometimes you just got to give them some options about, well, tell me about this. Is it like this, or that, and just kind of give them some feedback and then kind of divulge that way. So, but like the way you ask the question, it can be so many different ways. Yeah.
Oh man. How long have you been practicing, Matt?
So I graduated in 2016. And then I've probably been doing pelvic health for the last like 3 years.
Very cool.
Yeah.
So I ask this because I like interviewing, the giants or the experts in our field who have been practicing for decades and decades. And it's kind of hard to, obviously I love talking to them, but sometimes it's so, I've elevated them so much in my mind of like, wow, they just have it all figured out.
Yeah.
And meanwhile,
I'll never get
I'm
there.
over here like,
Yes.
did I do
Yes
this
to
today?
this.
I don't even remember. And so it's really nice to talk to, like you and other therapists who are saying, this is something we're still working on. This is something that we're still practicing. This is something that I'm learning, because it feels like there is such a separation sometimes of like, I'm never going to get there. And then I hear people like you and they're like, I'm still working on this. I'm like, oh, thank God. Oh, thank God.
Well, I think to your point, I think that makes a lot of sense. And I think sometimes those people are still working on certain things and it doesn't go all perfectly right, but they're here to tell a story or express their expertise in something that is like so specific, right? And there's a specific lineup of questions, and it might not take this turn that we're taking on because we're of similar like experience levels or backgrounds, and that sometimes could be a good conversation about these things that everyone could maybe work on a little bit more. Yeah.
Oh man. This has been a really cool conversation. I'm so glad I had you on here. Like, I feel like I'm listening and taking notes as much as I know other people are listening and taking notes right now. So this is amazing. Man, this is really cool. Okay, I'm going to pivot it back to a little more kind of like prostate cancer specific.
Sure.
So we've talked a bit about what are the treatments, what are the side effects, how do you work on them? What are you doing in therapy as a pelvic floor therapist working with prostate cancer survivors for the PT, me, and other listeners who are not pelvic floor
Sure.
trained, but know that their patients are experiencing some of these, side effects and impairments.
Sure. So if we're talking about like a triage situation, right? Or
Mm-hmm.
do I need to refer this person out or not? I think we hit the point home. Like that's a subjective question piece. Like I need to
Yeah.
ask more questions and learn more stuff and that kind of things. Well, if someone's
Yep.
just like, well, maybe I don't have that service in my neighborhood, or maybe there's not a person willing to treat this person, or they don't have that piece of that puzzle right now to go somewhere else, right? Well, what can
Mm-hmm.
you get started with, right? Sometimes that's some dietary changes, right? Sometimes like bladder irritants can be a big, contributing factor to leakage. Sometimes pelvic floor muscle strength and hip strength, I think, is very important. Glute med, rotators, like that kind of stuff can be very helpful for, like, as an adjunct for pelvic floor strengthening. Um,
Mm-hmm.
you know, Obviously, there are some oncologic therapists who do prescribe Kegels and like pelvic floor contractions and that piece of the puzzle. And that might be somewhere you just like, from an education standpoint, and say like, were you ever taught this? And are you doing it? Was it helpful? Like kind of getting some information about that piece of it and
Mm-hmm.
supplementing that into your exercise. Oh yeah, I got discharged from pelvic therapy, and I've had no problems. But now when you make me do the deadlift with 50 pounds, that's when it comes back.
Mm.
Okay, can we troubleshoot that? What skills did you remember from before? Like, what can you pull out of your back pocket to help me help you, right? And maybe that is something that you can help triage and see how they do, right?
Mm-hmm.
Versus sending them back to the pelvic therapist for a whole other plan of care. And they might need that. At the end of the day, they might need that because their functional
Right.
stats might be different. And again, this is how we work as teams, because I might see them at a certain functional level, and then you might get them to a different functional level because of the rehab process that you guys take them on, and that changes their capacity, right? And then they need
Mm-hmm.
to come back because their pelvic floor or their pressure system or X, Y, and Z is not able to handle that capacity, right? So like this is a collaborative relationship, but sometimes they need to they could refine things with skill sets that they already know. Like I'm huge on telling patients, like, I don't care if you know an exercise. I want you to learn the reason behind and the strategy behind it, because there's gonna come a time, and I always give these like crazy examples, like you might want to go skydiving or like ride a unicycle or something crazy, and we never talk
Mm-hmm.
about that. And I don't want you to be floundering because Matt never told me how to ride a unicycle. But
Mm-hmm.
here's like the thought process, like the thought process on how we tackled X relates to this, and I can use those skills and strategies. So sometimes, like as therapists, we can help kind of like bring that out in patients. Um,
Mm-hmm.
I don't have a great example in the prostate cancer world how I do that because, well, I guess sometimes it's like, what did the doctor say about that? Like, what did your physician team talk about when this happened, right? Or this medication or this side effect? Like, obviously, I'm not a pharmacist. I'm not a medical radiation oncologist. I'm not those people. But like,
Mm-hmm.
what was the conversation like? Do we need to loop them in? Like, sometimes we need that side of
Yeah.
things too. So
Yeah.
that's probably how I do it. But as I think an oncology therapist, like sometimes getting some of that pelvic health information, and maybe that's sometimes like where patients or people, therapists take a course, like take an introductory course, right? Learn a little bit.
Mm-hmm.
Um, Beef up your triage skills and basic intervention skills. Learn how to help someone do a pelvic floor muscle contraction. And then if they're not making progress or they're not successful or they need a deep dive and you're done with doing what you need to be doing, well, send them
Mm-hmm.
off or co-treat or, loop in your pelvic health friend who can give you information on when the right time might be to make the transition, right?
Mm-hmm.
And I think sexual side effects is probably the biggest one that needs to be done for,
Yeah.
like in the kind of more pressing manner, or bowel things sometimes need that like more deep dive.
Mm-hmm.
Again, like if the patient made a decision to go to oncology therapy and they know they're going to be exercising, but they have some leakage that they're like quote unquote okay with.
Mm-hmm.
Maybe that is a scenario where like, all right, well, do you know this? Sometimes they just don't know it could be changed. You know, referral pathways are like
Yeah.
so interesting sometimes, and sometimes that's the resources that the physician team has on hand. Maybe they don't have a pelvic therapist, or maybe they don't have an oncology therapist, and they get
Mm-hmm.
the referral pathways is only to pelvic health or only to oncology, and
Mm-hmm.
the therapists know each other, but the doctor team doesn't necessarily know both services are available. So
Right.
sometimes that can be how it's done too. Um, but I think sometimes it's just like coming back to asking questions to the patient, but helping them manage what, again, their goals are, right? Coming back full circle.
Mm-hmm. Mm-hmm. You really wrapped this up very nicely, Matt, and called back so many themes of like what we've already talked about. This was masterful. Masterful. For the therapist who is brand new to treating a person diagnosed with prostate cancer, what are some of the, I guess, like low hanging fruit of you can get started helping this person this week
Mm,
with? Like, what are some of those things that, oh my gosh, I'm overwhelmed. I don't even know what to even start with this patient. What are some things that you would recommend or encourage them to look at?
sure. I think sometimes it's, you know, are you hydrating? Like so many patients walk in the door after prostatectomy and be like, I don't drink anything. Water, coffee, soda, anything. And that just like wreaks havoc and that spurs on the leakage process. So trying to
Yeah.
encourage them to be hydrated, right? How often are you going to the restroom? You know, oh, well, I'm going every 15 minutes because I don't want to leak. Well, again, one of those things is like maybe that's a behavior we need to start shifting away from. So I think those
Mm-hmm.
are probably two really easy low hanging fruit that are
Love it.
behavioral, that any therapist can do. Um, and again, like I hate to bring it back full circle. Like, what are your goals? Like, are you really here for fatigue and that kind of thing, or do you need a pelvic therapist? And how can I get you to one? And
Yeah.
sometimes that is like, let's do some Kegels with some of the other exercises that we're doing, or pelvic health or pelvic muscle contractions with exercises that we're doing. Um, I think it's sometimes hard, and I think sometimes like a turf battle, quote unquote, happening where it's like, no one else can show someone how to do a pelvic floor contraction, and pelvic therapists can't treat cancer-related side effects, and sometimes I think that thought process gets put out in the world, and we can do both. Like people can do both. I
Mm-hmm.
certainly do both, but I think there's sometimes a limitation on, when someone's like in the thick of hormone replacement therapy and I'm done when I'm done with pelvic health. Well, that's typically a referral process that I'll make.
Mm-hmm.
So I think that's like knowing your limitations is important, and knowing what you're really like skilled at. And you can always learn more. Like you can always learn the other side of the coin. Um,
Totally.
but low hanging fruit is definitely hydration. How often are you going to the bathroom? What are your stool like? Right? Like, are you like straining out to wazoo on the toilet? Are
Yeah.
you constipated? Are you eating enough fiber? Like, that is a big driver to leakage too. And like, we any therapist can talk about that.
Absolutely.
And some of it's just
Absolutely.
like, and yeah, some of these things might need, deeper dives. But when we're talking about like what should the average oncology therapist know? Hydration, bathroom habits, bowel habits. Those are the big ones, I would think.
So, and I feel like, again, these are things that we should be talking about with our patients anyways, regardless of
Yes,
diagnosis,
yes,
because
yes.
everybody's got to pee, everybody's got to poop. I would say most people, if not everybody, want to and need to have sex at some point. So
Yeah,
like these are questions we should be asking our patients anyways. It's just making sure that we're, keeping certain things in mind.
yeah.
This is kind of my last question, Matt. What is something that you wish you knew earlier, or what you would want an OncoPT to know about treating a person with prostate cancer?
Hmm. I'll probably spin this as what would I want to know sooner? And I think, and this was maybe a generalization for me going into pelvic health. I was like the first couple pelvic health therapy, patients I saw, I was like, I would give them a whole spiel about you should be comfortable and like feel free to tell me anything you want, and like no one really trains you how to like talk about these things, right? So
Yeah.
in my mind, it
Yeah.
said, okay, well, make sure they feel that you are comfortable talking about these things, and that didn't work great, I think. um, so I think just treat them like everyone else,
Yeah.
like treat them like act as natural as possible. And to me, I don't do anything else. The way I talk about knees and backs and shoulders is the same way I talk about bowel, bladder, or sexual function things. And I still have that kind of air of clinicalness to myself in the way I talk, but I'm still sarcastic and I still comment on things, and you still treat that person like a human being, and like the conversation is still
Yeah.
the same, right? So I think if someone in the oncology world is, I don't know how to ask patients about this, and this question comes up a ton. I think that advice is just like find a quiet space where you can talk to someone in private and just, hey, sometimes these are common side effects. Like, do you have any of these? Just like you
Yeah.
would treat, do you have any clicking, popping in your knee? Like, that's the same way you would talk about it. So I
Totally.
think for me, the thing that I wish someone told me on day one was like, just act natural, be yourself, talk to them the way you would talk to anyone else. And yes, there's some conversation that might need a little bit of air of, seriousness to it. Um,
Yeah.
but sometimes they want to, they're like, they've been through so much and through so much like
Absolutely.
medicalization and poking and prodding and, paper gowns and all that stuff. And they just want to be normal and act normal in front of someone who understands what they're going through, right? So
Mm-hmm.
I think that's my parting comment.
Mm. Matt, where can people find you, follow you, learn more from you?
So I'm big on LinkedIn. I post
Yeah.
somewhat often.
Can attest. It is amazing. Amazing.
So feel free to message me. I get a decent amount of messages about pelvic questions or where do I find someone, or X, Y, and Z. I am always happy to talk pelvic things and happy to talk about how do I get started. And um, again, my passion in the pelvic world is male bodied patients and prostate cancer and other, colorectal cancer, testicular cancer. Like there's so many other things too, that kind of
Yeah.
in this pelvic world. But I am passionate about helping be, kind of like how Jill was to me. I want someone to say, wow, I'm interested in what he's doing and I want to do that too. So
Yeah.
reach out to me because I want more people to do this. And the more we all talk about it and the more people do it, the easier it's going to be for everyone, and the more patients are going to have access to care. Like, that's
Yeah.
awesome. So, reach out, and you can put my email in the show notes too.
Perfect. I will definitely do that. So I'll link to your LinkedIn profile. Because again, I was really hoping you were going to say LinkedIn because I was like, that is where the gold is. So I'll do that and then also email. I'll get that
Sure.
information and then link that in the show notes. Gosh, Matt, this was wonderful. Again, I know I invited you on here to talk about prostate, but I feel like you kind of also talked about genuinely like how to be a better PT.
Mm-hmm.
And I think that's a theme that very unintentionally but very welcomed is coming out more, and especially some of these episodes I've had of late, which is really exciting. And I'm really, really glad that we had this conversation today because I learned a lot and I'm looking forward to implementing this into my own practice. And I know that my listeners are really going to enjoy this episode. So thank you
Cool.
so much.
You're welcome. And we can always do a part two on like actual
Yes.
prostate cancer care. So happy
Yes.
to do that.
I'm going to have you back. I'm going to hold you to it. It's happening now.
Yeah, anytime. Anytime.